for about 17 years, and 3 of those years here at Dynamic. And this is Scott.
I'm Scott. I've been a PT for almost 10 years now, and same thing around almost 4 years here at Dynamic. So.
And as we always like to say, we are therapists and not public speakers, so bear with us. We hope not to keep you too long tonight. The most important thing here is just for you guys to get a better understanding of just shoulder pain and what do you need to do for it? What can you do for it? And why do these things happen? When it comes to getting to know us a little bit, we'll do that a little bit later. But I want to just go through, get your first name, what shoulder, if it is you, might be bothering you, and a pain number. And maybe in one activity that is aggravated by that particular, the shoulder is aggravated by that particular activity. Thank you, sir.
All right.
All right, I'm going to start with you right here.
Okay, Larry Peart.
Larry. And what shoulder do you have pain in?
Right shoulder,
Right shoulder and pain number?
about a 5.
Out of 5. When does it hurt you the most?
I put the keys in my ignition.
Keys in the ignition, all right.
Going for a reach high, you know.
Gotcha. Okay. All right, you sir?
Yeah, I'm Louis Bernard. I had surgery on this shoulder. It bothers me a little bit, but now it's the right.
No, it's the right. Okay.
And there's a little cracking and stuff. And
Gotcha.
and
So
going high.
overhead reaching and
Yeah.
okay. All right.
I'm Sherry McCloskey. I was here for a friend
Okay.
information, so.
We can pretend, you know.
Yeah.
You can look.
The back of my
FaceTime your
neck
friend.
hurts because it's very carried with stress.
I'm good at finding things, so we may.
Yeah, you never know.
True. Y'all
We'll,
can
we'll
evaluate
still
me.
be watching you. When we ask you to do things, we'll still be watching you.
Okay.
All right, right over here.
I'm Scott Edgar, and actually, I guess when I sleep, I have the most
Okay.
pain.
All
Yeah.
right.
Same here.
I have the same problem. Is it Bernard? Is that his first name?
Louis, yeah,
Louis. Same thing then. We have the same problem.
Sleeve,
All
yeah,
right.
sleeve.
It's the right shoulder.
All right. Well, y'all might get some little hints tonight. All right.
Steve,
Hi, Steve.
and I seem to get pain, it seems to wake me up at night sometimes, and I don't realize until I'm after up. And then the next day, I'm trying to figure out, what did I do?
What'd you do?
And that pain could be a 7 or an 8, maybe a 9. It just gets to be a point where I'm waking up and I'm realizing this, and maybe some Tylenol or ibuprofen, I'm not
Gotcha.
sure.
Do you know what position you're sleeping in? What position do
I
you go
always
to
try
sleep?
I can't tell you that. But
Ah,
I do know in
okay.
my workplace, same way with Louis, and up here,
Overhead.
now, right now I'm heavy, and ironically, I swear, I'm gonna reach my wallet.
It's still-
Ah, that's
Right
a
here,
good
I
one.
mean,
That's a
but
good
some days I
one.
can do it, some days it kills me to do it, so I don't know.
All right, good. All right, last but not least, over here in the corner,
Dave Sepulveda. It's the right shoulder.
right shoulder. All right, pain number.
Here it gets hard to go further.
Yeah, that's pretty stiff right there, right shoulder.
A lot right.
All right, I see, so yeah, I know.
I got a question.
It's the right shoulder night tonight.
I go to Tulane Sports Medicine.
Uh-huh.
He did MRI and x-ray, said my muscle has snapped in half. So they want to take a muscle out of my leg and put it, join it all
Right.
together.
Right,
Is
How-
rehab gonna help me
so,
before or
we-
after?
so
No, after
we will get into that a little bit later, and I'm glad you brought that up.
Remind us.
We're gonna star your name there, because we are gonna very much answer that question there, okay? Anybody else? Did we miss anybody? I think we've got everybody. So a little bit about what we're gonna go into now. Understanding anatomy, understanding the mechanics and how the shoulder girdle works is important, because our shoulder joint is a very mobile joint. So even though we have as far as the hip, it's the same type of joint as the hip, but our shoulder is much more mobile. It's made up of 4 muscles.
here's your right shoulder, and this is looking at the front and looking at the back. This is what we have drawn here, okay? Front side, back side. Now, if you take all of your larger muscles, your upper trap, off, you get just your pure rotator cuff muscles. Okay, so here would be your spine, and it sits like this. Your rib cage is coming in through here. Okay, so first things, you have 4 rotator cuff muscles, and you can follow along on that sheet where it has the blanks. You can fill in the blanks there. So you have your 4 rotator cuff muscles. Okay, and it is a ball and socket joint. And those muscles help to move the shoulder. Okay, so primarily, when those cuff muscles are working to their full potential, anytime you go to raise your arm overhead, those cuff muscles will pull that arm down just slightly to where when you raise up, you don't get any pinching and grinding in those joints, okay? So the reason I like to use this model is because I can dislocate it pretty easily, so it's been well used. So if you remove all the tendons from the cuff, you can see that little groove in there. That's your glenoid cavity. That's that cup that we talk about, okay? You can see how shallow it is, just like a baseball and then a saucer, okay? You can see how much mobility it has sliding around in that joint, okay? So your first line of defense is a very strong cuff, and that helps to keep you secure in that socket, okay? So if one of these muscles isn't working like it should, every time you go to raise your arm up, it's gonna jam up into the top. And usually when we watch people, you watch movement, and the first thing you'll see is this. And that is that ball jamming up in there and pinching those tendons as they come through, okay? That first little pinch that you feel, as soon as you move it out, that's your body trying to tell you to stop. So what do we normally do? You keep doing it until you get up to the heights you want to go. So now you've made it extra mad, and now things start to swell, and that's when you start getting the bursitis and the inflammation through there, okay? So the next section down is the 4 areas that work together during your movement, okay? And so I'll just keep going back and forth. The first one we'll talk about is the neck. And I forgot my little spinal model. Basically, your neck has your vertebrae and then your disc in between, okay? You've got to have normal mobility in those discs in the neck as well, okay? So you tend to see people sitting a lot at the computers or during the desk. And Mr. Lewis, we're working on this a lot with you, and they're typically forward positioned. So what it does is it increases the curvature in the neck, and it throws off the balance on those discs, okay? So those discs are made to have equal pressure to where every bit of the disc is centralized. So once you start changing the positioning there, you tend to push some of that disc material either back into the nerve roots or forward, okay? So that's when you start getting some of that nerve pain down. So like the gentleman sleeping, usually people sleeping overhead, you'll start to get impingement of those nerves. Sometimes it'll lead to pain shooting down the arm. Sometimes it may just send it to the shoulder. Okay, so that's where we've got to be careful with how we're looking at things. Okay, if you move down in the spine to your thoracic spine, that middle part of your back between your shoulder blades, that area is curved for natural purposes. But what happens is if it gets stuck and it doesn't move right, then you can't get your arm overhead because that scapula has to move on those from the rib cage and the thoracic spine. So if it's stuck there and you can't get that extra bit of mobility, then you're going to start irritating the shoulder by compensating a little bit
And
too
you can
much.
kind of feel it if you want to try it on your non-painful shoulder. Just kind of follow your collarbone and raise that arm up, right? And
That
feel it,
collarbone has to
and feel
move.
feel that collarbone move.
Mhm.
So the shoulder, our shoulder, in order to move here, all of those parts, so the nerves that come from the cervical spine have to send the appropriate signals. Our collarbone has to be able to glide. Our shoulder blade can't get stuck. It can't get stuck in this position. And how is it sitting? We really take a look at how is it sitting against the rib cage. The ribs also have to be able to expand. And so all of those 4 parts are super important when we're talking about shoulder pain, because if one of those is out of sync, then we have a mechanical problem, and that's where our irritation and inflammation is going to come from. Any questions on that portion? Does that? Yeah. So as far as success stories, I mean, I worked at a sports medicine clinic a while back, and we did pitching analysis. So when it comes to shoulder pain, it's not always just about, oh, I need to strengthen my rotator cuff, right? Because those ball pitchers, they were strong. They were super strong. The important thing was we, number one, had to decrease what was aggravating. What were the mechanics? Were the mechanics off? What was the timing of those muscle contractions? What kind of hands-on movement? Was it their shoulder blade not sitting right? Was the humeral head not depressing at the right time in order for that acromion not to get into the wrong position? I mean, where that supraspinatus muscle that can get caught between the bone up here and the humeral head. So it's a lot more to it than just, oh, I need to strengthen this muscle.
I have a lady now who came about 2 weeks ago. Her doctor told her that she had frozen shoulder, and then she went and have another opinion, and the doctor told her that she had a complete tear without doing an MRI. So it's like, that's a little hard to tell. But she was having a ton of pain front of her shoulder, kind of pinpoint right here. She's like, it hurts every time I try to move. Well, she was so forward, her scapulas were so rounded away from her thoracic spine and rib cage that it was compressing everything in the front of her shoulder. So passing along the front side, you've got nerve bundles that pass through the axilla. You've got tendons, your bicep tendons passing through there, and it closes off that whole spot of that whole area of the shoulder. So within a couple weeks and focusing on getting her shoulder blades back into her normal position with a few very simple little stretches, she was 75% less pain, and we were getting her upwards of 140 degrees of motion. When she walked in, she couldn't do this. So she was like, is my rotator cuff still torn? I'm like, if it was torn, you wouldn't be lifting like you're doing. So people jump to the rotator cuff very often with full tears and adhesive capsulitis for the
And
shoulder.
that kind of leads to what you were saying earlier, you know, full snap of the muscle and things of that nature. You know, there was a very interesting study that was done of 100 people that did not have shoulder pain. So no pain symptoms. But they took those 100 people and they underwent those diagnostic tests, those MRIs, x-rays, and they separated them into age groups. So of the 50-year-olds, how many positive findings do you think they found? Whether it was a rotator cuff tear, a fray, so there's different grades of rotator cuff tears. So we call that positive findings. Arthritic changes, spurs.
Bursitis was included in that too.
Bursitis. What percent do you think showed positive findings on the MRI, but no pain in the shoulder? Any guesses?
50%.
Close. 80%
Wow.
of 50-year-olds, no pain, still showed positive findings. Next, separated into 60-year-olds. What percent?
90.
90. You got it. No shoulder pain. 90. She got that one. I told you we would be watching.
Yeah.
All right. So now comes to our 80-year-olds. How many positive findings did we have?
100.
Once again, just winning over here. 99. 99%. 99%. Anybody have any thoughts on that?
The structure changes as you get older.
Yeah.
So it's a natural
Exactly.
part of aging.
Probably because everybody's back's going out, and everyone's going to their body compensate for it.
So the
Backs
key,
and knees.
yeah. So the key is if you keep everything stable and central like it's supposed to be, even though you have those findings, you're still able to move correctly. But once you start getting here, now those findings come into play because everything starts to pinch and grind.
Here's a question. Spurs and arthritis.
Same type of thing. It's a bony growth. Usually a spur has an extra little projection on or extra little hook on it. So where it gets a little bit more of a bad rap compared to just your typical arthritis. You know, you get them commonly in the shoulder or in the spine as well. But it's just an extra bony growth that
From
most,
abnormal forces.
that little pinch,
Hence the imbalance of those 4 areas, the neck, collarbone.
So basically, you work it in a narrow peripheral, and it works its way into that little
Yep.
scar.
You remember that first little pinch is that body getting irritated, that area getting irritated, but if you keep grinding away at it, now that cartilage starts to get degraded. As that cartilage, that's your barrier to the bone. Once that gets degraded, now you're starting to get bone on bone. And bone on bone is gonna cause bone growth, just like in the knee. You start degrading that cartilage, and now you start getting bone on bone. Wolff's Law is a very common thing that they teach us in PT school. A bony growth, and you know bone on bone is gonna cause more bone. It's just the body's response to try and protect itself from irritation. Okay? All right. 5-minute miracle time.
You
All right.
got it.
So can I have everybody stand for me? So we're gonna be looking at your shoulder range of motion and your neck as well. Okay?
No.
You can find.
So what we're
Miss
gonna do
No
is,
Pain over
what
there.
we're gonna do is we're gonna do both arms straight in front, thumbs up, high as you can go. If it's your irritated side, don't do it. And then come back down. And then let's do cervical rotation to the right. So looking to your right. And then to the left. Good. Let's do arms one more time. Everybody kind of had it equal. So I'm looking for somebody with a little bit tougher. Nice try.
Feeling pain when I do it.
Yeah.
I can do it.
Good. I'm gonna cautious of that right shoulder because of how irritated and damaged it might be. I'm gonna pick on Mr. David for a second. Come on up. You can put your arms down now. Let me get my mask on. And before we have a seat, we're gonna have you turn and face the front. Face everybody.
Y'all can have a seat, or y'all can stand, whatever y'all want to do.
So I want you to show everybody kind of how your motion looked. So go both arms straight in front of you again, all the way up as high as you can go. So from here I can tell his right arm is a little bit more limited than his left. Okay, and then put your arms down.
That's coming down, I feel.
Feel that. And now turn
I feel it here.
right there in the front. Okay, we're going to turn head left and then right as far as you can. Good, and then to the right. Does either side feel a little worse?
This side.
Come to your right, yeah. All right, what about turn face this way? And we're gonna go arms up your back. So we're gonna do right arm up your back first, as high as you can tolerate,
There it is.
and then the left side. There's a big change, okay? So I'm gonna have you come have a seat on this mat here. I'm gonna pick on the right side of his neck. I'm gonna lower you down a little bit more. All right, so arms relaxed at your side. A little tender right there. Okay. So what I want you to do is, you're going to not let me push your head to the side. Okay. And then relax. And then again.
That's my left shoulder.
Good. And then one more time. Good. And now I want you to tilt your head to your right a little bit. Good. And then relax it. Hold right there. Don't let me
I'm
push.
trying to military action.
Good. Hold one more time.
I'm trying to keep from getting that.
And hold one more time. Very good. So come stand in front for me. We're going to repeat. Let's do your arms straight in front, as high up as you can go. Keep going higher, as high up as you can tolerate. Good. So now, not great, but now his right is equal to his left. And then come back down. Feel the pain through there. So we didn't do much for that. Now turn your head to the left as far as you can, and then to the right. How does that feel to the right? Better? About the same?
Well, it feels about good.
Good.
Yeah.
Okay. So picked up a range as well. Okay. Let's turn. Push back in. So now we're gonna go left arm behind first as the comparison, and now the right side. Good. So a little bit higher. So with one little treatment, And now let's turn face to everybody again. So what we focused on was the neck, and you can see how it plays in. So down the side of your neck, you've got muscles and groups that are coming all the way down and attaching to your shoulder blade, to your collarbone, and what's called your first rib that sits deep in that little groove there. So as all those neck muscles start to get tight and gored because of the shoulder, they cause that first rib to elevate and get really stuck up there.
There's a lot of little nerves that run right.
So it's full of nerve areas, so that's why it gets so painful. It'll limit your raising your arm up. It'll limit turning your head to the same side. So basically, I pressed down on that first rib and had him do just some isometric contractions to fire those muscles and then relax them. Fire them and relax them, and it shuts them off. And then it allows that rib to go down and give him some extra mobility. Okay? So, did we cure anything? No. Probably saved him a little bit of irritation tonight when he's trying to sleep, but tomorrow it's going to go back because we didn't change the cause of that, which could be weakness through the middle of his back, could be it's all extra muscle guarding for here, and then whatever's irritating that shoulder from the start, whether it's a rotator cuff issue or a bicep issue, there's all kinds of things that could be causing that motion. Okay? Thank you.
All right, so that brings us to our next point where the hands-on treatment is super important. Like I said, I've been a physical therapist coming on 17 years, but about 20 years ago, there were some statistics that physical therapists don't really like, right? So 20 years ago, physical therapy was very different than it is now. So we have our lovely little pie graph. Are you good? So our little graph kind of looks like, oh, that doesn't work. It looked like that. So we have our lovely little circle here. And physical therapy, about 25% got better after physical therapy. No better, no worse with physical therapy. And what was our little number here? I don't even remember. They got better, but it didn't last. So our better, but didn't last. Okay, well that's not very good for physical therapy, right? So luckily I came through school. They were doing a little bit more hands-on treatment. So they were looking at all of those areas that we talked about earlier. And so now what it looks like when they did a new study, I don't know where my little eraser is, you have it? Oh, right there. So now, physical therapy with hands-on treatment looks like that. So now we have 90% that not only do they get better, it lasts. And we definitely attribute that to the hands-on treatment that we give here, specifically at Dynamic, because I know, again, I've kind of worked in other areas, and I know specifically that only about 5% of the physical therapy clinics in our area do the type of hands-on treatment that we do here. Important things when it comes to what do I do? I have this pain, and you can choose to, of course, everybody wants to kind of get back to normal, right? Get back to sleeping without pain. Doing any of those overhead activities that just pinch and going to continue to aggravate, continue to limit our range of motion. We hadn't kind of looked at our sheet in a minute. I think we've gone through, we're on about number 3. So this is where I'm redirecting you kind of back to normal, your first steps. Does anybody have anything written down in there? If your shoulder pain is reproducible, Because if we can change, if we can cause the pain, then there is a biomechanical component there. There is something there that we can fix. Of course, red flags are just that constant pain where nothing changes it. Nothing. You can't make it worse. So those are the types of things that we do in physical therapy, because we are your musculoskeletal neuromuscular experts, and we're working on these systems, working together. I laugh because my dad has owned a construction company. He's had a service company our whole life, and was just a really good repairman, right? And I always say, he's like, why didn't you go through the family business? I said, Dad, I am in the family business. I just help fix people and not appliances. That's just how it goes. So we take a lot of pride in what we do, because we're conservative treatment. I always consider us kind of that first line of defense, where we're trying to do everything we can to save money, to decrease pain, get back to the activities that we want, but ultimately avoid surgery if it's possible.
Absolutely. All right, so looking at number 4 on your sheet, so you have the number 1 biggest mistake that shoulder pain sufferers make is what? What do you think it is? They ignore it. That's the big thing that people do. You do it once, it hurts, so you keep trying it to see if it's going to stop hurting. And that's usually not the case. Okay?
Oh, we had a few people that talked about sleeping, pain with sleeping.
Let me grab a pillow real fast.
I know, you think we...
We put them all.
I know, look, we cleaned up way too well. Cleaned up way too well.
All right, so who has to sleep on their back because of their shoulder pain? What about on their side? Who tries to sleep side lying?
Try.
Okay. Try. You usually flip-flop a lot.
Yeah.
So typically, I'm going to use my right shoulder. If that's my painful shoulder, sleeping on your left side typically is the most comfortable position. But if you're pinned here at your side, so you're laying and you're pinned at your side, you're putting your shoulder in a very tight position, that jointly tight position, okay? So getting a pillow under there is going to help to keep that shoulder joint a little bit looser. So 2 reasons that works. In this position here, all the cuff tendons, especially your supraspinatus, that comes out across the top and attaches down on the outside of the shoulder, that one gets pinched and gets stretched a lot. So you think sleeping all night with that shoulder pin there is going to really irritate that muscle. So the first thing you do when you wake up is you usually stretch, or you usually raise that arm and do something, and all of a sudden that tight muscle that you just had pinned here is trying to work and it's not happy. So getting that pillow here is going to help keep that shoulder in a loose pack position. It keeps that tendon from getting overstretched all night long. The loose pack position is very good for blood flow at night. Okay, the blood flow is what's going to bring healthy blood to the area, healthy cells for healing purposes. Okay. You get tired of sleeping on your left side. When you roll onto your back, keep that pillow there. And now, as that end of that pillow supports your arm, it's going to keep you in that loose pack position as well. Because this, laying on your back and that arm hangs back here, puts so much stress on the front of the shoulder that once again, it's irritating everything in the front. Okay, so pillow for support is going to be very crucial. For those of you that end up rolling onto your hurtful side, typically your best position is going to be having your hand supported on your head and getting that elbow about 90 degrees, okay? Up here is going to irritate your neck and your nerve roots too much. But getting that arm there underneath with the pillow here is going to usually give you a good sleeping position, okay? And for those of you that like to sleep on your stomach with your arms up here, if you have a face hole that you can breathe through, great. But if not, you're turning your head either one way or the other, and then you're going to be constant neck issues, okay? So try that pillow positioning. It's not going to come easy. It's going to take a few nights to get used to, but it will pay some dividends, okay?
All right. Oh, we already talked about the ignoring it. So, question is, what are 3 things you can do about your shoulder pain right now? I gave y'all an answer to the first one already.
Use a pillow.
So that's alter it, right?
So the first thing would be.
Get physical therapy.
All right.
Well, though they say,
Posture.
you can ignore it
Or address it, huh?
or address it.
Yep.
Some people address it, they alter it with medications, injections, right? But the same thing applies where how long is that gonna last? We go back to our little graph, what has been shown, I love those particular modalities or treatments, only in very specific cases. But ultimately, yes, we want to decrease the pain and inflammation so that you can move better. Because pain is an actual inhibitor of muscles at times. So hence then the mechanics of everything else, it's just, it throws everything off track, especially for the shoulder.
So who's had an injection, at least 1 injection? What about 2 injections in the same shoulder? What about 3? Anybody with 3 or more?
I had one in the
neck.
neck.
Okay. So usually, those drugs are pretty powerful. So more than 3 in one body part over a certain period of time has actually been shown to degrade some of the cartilage again. So you're taking an area that's already really irritable, and you're giving it so much medication that it's starting to rapid that degeneration. Okay. So that's never good. Now there's times where people come in with severe shoulder pain, and you're like, you can't get them to move, you can't get them to relax. We'll call the doctor, we'll text the doctor, be like, look, can you give them 1 injection, calm it down? We'll get a patient in here the next day and try and work on that motion while they're having less pain. Okay, because once they're really guarded, it's hard to break that cycle due to pain. Okay, so there's times where injections are needed, but repetitive injections are where you start getting yourself in trouble. Okay, and a good surgeon or a good doctor knows that. There's some that are always want to just, oh, let's do another injection, let's do another injection. So that's where it's nice to know what the aftermath is if you're not careful.
Right. And that kind of leads us to the 3rd one where it says handle it, right? Our handling it is finding that underlying cause. What is out of balance, right? And do we need to then move you to particular medical management when it's appropriate? And we might do an evaluation and we'll say, well, yeah, this might be, we're gonna be able to help you with this, but ultimately you might end up having surgery, but we're gonna help prepare you for that surgery. We're gonna make sure that the blood flow to that area, it is not compromised at all, right? That way you have the best success at a successful outcome of your surgery.
So like with your shoulder, has it been diagnosed, and has it shown on MRI or any other imaging that it's been torn completely? Which muscle? Do you remember exactly?
You said it comes from the shoulder blade over.
Yeah, so typically your most common one is that supraspinatus, because as it comes over the top of the shoulder and it passes under the groove of that bone is where it gets pinched the most, okay? So there's people that live with kind of complete tears all the time. You learn to get stronger in the muscles in the other 3 cuff muscles. You learn compensatory strategies that help keep that motion, okay? So it's not always an immediate surgery type of thing. Because once that cuff muscle is torn, those nerves are torn with it. So you limit that transmitting of pain from the shoulder to the brain. Is those severe pain shoulders are typically the small tears or the partial tears, because those nerve fibers are still intact, transmitting that signal. Okay, but just like we said, the MRIs aren't conclusive with everybody. You know, we had a lady just about a month ago who she was able to raise her arm here, she was able to raise her arm here, and had maybe 5 out of 10 pain. She went to the doctor after about 3 weeks of no longer having improvement. Her MRI showed a complete tear of 2 of her cuff muscles. Nothing that she presented would have ever suggested that she had a complete tear. So she ended up going to have surgery for it. Because we were trying to tell her, look how much you're improving. You know, just because it's there, it's not limiting you functionally, other than her sleep was her big thing, which I get, I understand. So we'll see how she does. She comes back Friday for her first day after surgery. So we'll see if hopefully it was worth it for her. But she's got a long road ahead with 2 tears. But sometimes it's needed. You know, sometimes you can live with it. You know, so it's not always the surgery. Some surgeons will be like, let's cut first, do therapy after. In your case, rehab first is warranted, just like anybody, part of the knees, shoulders, backs. The more mobility you can go into a possible surgery and the more strength, the better your results are going to be. Because if you go in real stiff and guarded into that surgery and they're cutting on you and now inflammation sets in, you're going to still have that same amount. Okay.
All right. So that moves us down. Have we finished? We finished number 5. Have we looked at number 6? Did we finish all of those? The top 3 common causes are problem in the neck, impingement, and our favorite as physical therapists, poor posture. We love it. So, I always like to, this is always a fun one to do because it's such a good visual example of how poor posture affects shoulder range of motion. So, first time ever, right? Your physical therapist is gonna let you slouch. I want you to slouch as much as you're able to, all right? And I want you to try and raise your arms up. And you can stand up if you need. Coming down, slouch as much as you can, bring those arms up. Okay, it's kind of a struggle. Now I want you to sit up nice and tall. Good. We're gonna bring those shoulder blades back. We're gonna get our neck in a good, fabulous position. Make sure those shoulder blades are seated right here. And now I want you to try and bring your arm up. And that's a whole lot better, right? So that's that physical therapy, posture, fixes everything.
We never get tired of talking about posture. Everybody that comes in, when they first sit down at the arm bike or on the pulleys, it's like, all right, sit up straight, stop slouching. And that's the goal. That's the goal because you can feel the difference. Okay, you take in a shoulder that's already really irritated, you close it down, and now you try and raise it, and everything's getting mad. But with just a few simple exercises, some stretches, some hands-on treatment, relaxing some of those neck muscles, you get much freer motion. Okay.
All right. So, what does successful, non-invasive, natural treatment look like? Our hands-on physical therapy. And just like we've kind of said all evening, the hands-on to move the shoulders, surrounding joints, make sure everything is moving appropriately. Make sure there's nothing that is stuck or limited in the shoulder blade, in the spine, in the collarbone. And then, of course, our favorite, what Scott had demonstrated earlier, our glenohumeral joint, right? Sometimes it just takes a little bit of movement to just get that head of the humerus seated in the joint just right for everything just to fall back in line. Okay. Of course, strengthening exercises to retrain muscle memory, just like we talked about our pitchers. It's not always just a strength issue, it's a timing issue.
So how many have gone to therapy where you walk in, you see the physical therapist, and they're like, all right, this tech's gonna run you through all of your exercises. Or they give you a sheet,
Or
and they're
here's
like,
your
all right,
exercise.
do these, and then you never see them again. I've worked at a few that way, and I've been a patient at one, and it was probably the most ashamed I've been at the therapy clinic. So it's very key. Our technicians that work with us go through rigorous training. You know, they're assisted by us to make sure that they check off all the boxes on exercises. And with the way we're set up, we're able to see everything. So if we see somebody doing an exercise with an incorrect posture, we're down here helping. We're hands-on helping set that scapula, helping get that normal mobility, because if not, you're wasting your time. Okay, you're gonna keep flaring the joint up with every exercise, and then you're gonna have to go home and be like, well, therapy doesn't work. Well, it's because you're doing it incorrectly, because nobody's watching you, and that's the difference. Okay.
Okay, and then of course we have pain relieving modalities. So we know, you always hear about the physical torture, or my personal torture. Because, yeah, there are some things that we're doing that is creating an inflammatory response, but we need that inflammatory response in order to jumpstart phases of healing. Sometimes those are the only things that we can do to get to that proliferation phase of healing where the body is laying down collagen. That's how we remodel tissue, is by creating an inflammatory response. So yes, sometimes it's painful from what we're doing, but we're looking at our long-term goal, right? We might have this, but that's why we have our lovely pain-relieving modalities to help with that. We have our electrical stimulation, we have our laser, we have our dry needling, we've got a lot of modalities in pain taping. So we've got a lot of things at our disposal to help with the pain while you're going through all of your restorative and corrective exercises.
Yep, definitely the ice versus heat question is always a big one. Okay, usually I'll tell people if it's really an acute injury within 7 days or so, ice is your best go-to. But after that, I usually tell people if it's a couple month long thing, whatever you feel works best for you. If it's a heat that you get more relief from, then use heat. If it's ice, then use ice. If it's really painful, you can alternate. Do 10 to 12 minutes of ice, 30 minutes later, put on some heat for the same amount of time. But it's very important to wait for that 30 to 45 minutes to let your body regulate its temperature back to a normal spot. Because if you go ice straight to heat, then you're going to run the risk of burning yourself. Okay? But alternating ice and heat is also very helpful because you're getting blood flow rush to the area with the heat, and then you're getting blood flow leaving the area with ice. So it's a good way to pump new blood into that painful body part to help bring nutrients and cellular activity. Okay.
All right. Well, I hope, if anything, what you'll be able to take home is that you've learned something, right? But more importantly, we really hope that you seek to handle it, right? And of course, what that means is get to the root cause, getting back to normal naturally. And that's a lot of what we expect to see everyone in here at some point getting the help that you need. We do book up pretty fast here at Dynamic Physical Therapy, but we have saved some spots for anybody from the clinic tonight. If you'd like to get set up, and we'd have your own screen where we take a look at your posture and shoulder mechanics and things like that. So this is Sherry. Everybody should know Sherry at this point. And she'll be our go-to. Usually what we'll say is, I think everybody's kind of 5 or higher at this point, so I think everybody.
Good. I'm gonna
Maybe
send my
not-
brother-in-law there. He was gonna go someplace else. I'm gonna tell him to come.
Someone come over.
Yeah.
Because he knows so
And you all have a little pamphlet with a few exercises in there. Okay, give them a shot at home, try them. But if they start hurting, then stop them until we see you next time. Okay. All right. So if anybody would like to talk to Sherry and Teresa about booking a spot, please follow her up to the front. If anybody has any questions, feel free to ask them.
Thank you.
Okay, you're welcome.
Thank you very much.
Thank you, I'll see you on Friday.
Friday, so
Just a general question, like, I've never gone to the doctor to say, do I have a tear, right? Is that really the first step, is really just to go and find out what's going on with you?
no, because it's truly not going to affect the treatment that we're going to do for you. Now, if you were having a lot of nerve type symptoms, then 50-50, I would say, yeah, get a diagnosis. But right off the bat, no. Okay, we're going to do a full assessment of that shoulder and all the surrounding body parts and then come up with a plan that works best for you.
It's
Because
an
like
individualized
Yeah.
program.
Because a lot of times the doctor, they're going to poke around, they're going to have you raise, they might do some strength, and they're 75% of the time they're going to tell you if you've got a cuff tear and then send you on your way. Or they tell you you've got some type of impingement.
When you say it's a tear, is it a ligament, is it a?
It's muscle.
It's a muscle, so it's
Yeah.
a muscle tear, okay.
Muscle tear in the belly of the muscle, sometimes it's on the tendon.
Yeah.
Okay, but usually 75% of the time they're going to tell you it's either a rotator cuff tear or an impingement, which doesn't truly tell us anything. All it does is tell us that you're hurting somewhere. So we're going to assess it like we need to and figure out what's causing that issue. A lot of times it's postural, it's the way you sleep, it's the work you do. There's all kinds of things that can be effective. looks like the weather held off.
I know.
Nice little break.
Thank you, Mayor.
All
You're welcome.
right, thank
You're very
you.
welcome.
I'm Dr. Kate.
You're welcome. Nice to meet you.
All right, bye-bye.
I'll tell you, my cost is playing guitar stuff, you get the, you know, and
And you know who I am, right? You know I'm Bobby Linsberg.
Take care.
I'm sitting here.
You can,
You're like trying to
take this
place
part.
me. I'm way
You
to
can,
one
stop in
star.
the front, go ahead. So, hopefully we answered some
I
of these
was there last night trying to put winter bark release on it.
Oh my
So it's
gosh.
surgery.
Yeah, and then of course it's a
I would
people on
definitely-
big practice.
Oh my
Definitely
God.
try
I think the night
3-4 weeks of therapy before.
Let's see, okay,
To
so
try
we
and
have
build
my
some
other
range.
Yeah.
Even if it's just
Yeah.
passive.
Oh
Door.
God, I know, right?
Building some
Oh my
strength through the
God.
shoulder blade
I'll
itself.
watch them
Get some
sometimes
ability there.
overnight, except for
And
the
it'll
little
help
one.
you.
Yeah, my wife watches the little one, so we,
Yeah, Sherry,
No.
and that's
You can
what
request.
Yeah.
No.
What's behind me?
You, oh my gosh, yes. See, there's your trauma right there. Grandkids.
And
Yeah,
see,
good.
because
Oh,
Who
yoga.
you're
I don't even have
looking
anything
for surgery on the right side, do you know yet?
I wanna get it ahead of
Do you know,
time.
have you picked anybody to do the surgery when the time comes, or is it too late?
You know,
Yeah.
They replaced this shoulder,
Yeah,
and I went back to
the
him.
diagnosis and the
yeah.
medical
Oh, yeah.
He
testing
gave me a shot.
doesn't alter what we do.
6 weeks.
We will,
I gotta go back
we
in a
look
month.
at all those
Gotcha.
things, and then if we feel like it's okay.
Yeah, there's times where if it's not too severe, we can do some good, but there's times where it's maybe
Do a
too
little bit
far.
more.
You know what it is?
But are you ready to?
Or exactly what the doctor
That's
says.
right.
So it
Okay,
feels like
sometimes
you
we're
need a
better off
little
not
bit
trying to
more,
mess with it
you just need a
before,
little
so.
bit.
Yeah, well, good luck to you in the future. I know if there's anything we can do for you.
Yeah.
I will,
All right.
instincts.
I'll tell it, I'll show you.
All right,
Yeah,
take care.
please do.